Hello everyone. So today we are going to discuss the topic of mechanical ventilation. So the very first thing that we need to understand is what is mechanical ventilation. In very simple terms, the definition is the movement of gas in and out of the lungs of the patient with the help of an external device. This external device is called as a mechanical ventilator. Now, what does this machine do? It helps to the patient to take breaths. So it might provide all of the breaths to the patient, or it might support some of the breaths that the patient is attempting to take by himself. Now we shall go through the indications for mechanical. So I've enlisted four main indications for mechanical ventilation. So let's go through each of them one by one. So the very first that I mentioned is acute ventilatory failure. So a patient is said to be in acute ventilatory failure when he's gone into complete apnea. So apnea is one of the indications. The second is bradypnea. That is when the respiratory rate of the patient has reduced severely. All right. Then within acute ventilatory failure, there is apnea, bradypnea. So this we come to know through the respiratory rate of the patient. There are other values also that we have to look at, such as if the patient is developing respiratory acidosis. So how will we come to know that? By looking at the ABG of the patient, the arterial blood gas. So in that, if the PaCO2 goes beyond 50 mm of Hg, that is when we can see that the patient is going towards respiratory acidosis, CO2 retention is occurring, the patient's pH starts dropping and becomes acidotic, that is, it becomes less than 7.3. Then there are some other lung conditions such as acute lung injury, ARDS, wherein we say that the patient is in acute ventilatory failure and this patient needs ventilatory support. The second indication is impending ventilatory failure, wherein you know that this patient is going towards a situation of ventilatory failure. That again we shall come to know by noting the patient's by seeing the patient clinically, that you can see that his respiratory rate is decreasing gradually. You are able to see a gradual rise in the CO2 tension. You can see that gradually the pH of the patient is starting to drop. That is when you see that this patient is going into an impending ventilatory failure and he might need mechanical ventilation. The third indication would be severe hypoxemia. So the above two indications that we saw were wherein there's a lot of CO2 retention occurring. All right. The third indication is when there's inadequate oxygen delivery occurring in the patient's body and you need to provide oxygen to the patient. So that is the patient is in severe hypoxemia. How would you know that the patient is in severe hypoxemia? You look at the saturation of the patient. It's going below 75%. Or, you when you look at the ABG of the patient, you see that the arterial tension of oxygen, that is a PaO2, has reduced and is reduced drastically. It's gone less than 40 mm of mercury. That is when you see that the patient has gone into severe hypoxemia. Then there is another derived factor that helps you know if the patient is in severe hypoxemia. That is the PaO2 upon FiO2 ratio. So this ratio is nothing that's very difficult. I'll just note it down on the side. So if the saturation of the patient goes less than 75% or the PaO2 is less than 40 mm of mercury or if the PF ratio is less than 300. All right. So that is a situation that the patient has gone into severe hypoxemia. What is this PF ratio? It is the PaO2, which I mentioned up here, right? By FiO2 ratio. FiO2 is a fraction of inspired oxygen that the patient is requiring. All right. So that is a PF ratio. If that goes less than 300, the patient is in severe hypoxemia. The fourth indication will be prophylactically, you want to provide this patient with some kind of ventilatory support. Okay. So when is this situation that when does this situation arise? So post-operatively, after the surgery is over and you note that the patient doesn't have a good respiratory muscle tone, his breaths aren't adequate, he doesn't have a good cough, all right, you know that he's not able to take proper breaths, that is when you prophylactically put the patient on ventilatory support and gradually wean him out of it. Or if there's a situation that you know the patient has got neuromuscular diseases, he's going into gradual respiratory paralysis, this is a situation where prophylactically you want to give ventilatory support to the patient so that he does not get fatigued out. All right. Now let's see what are the types, the two modes of mechanical ventilation, two methods of providing mechanical ventilation. So one is the negative pressure ventilation and the other one is the positive pressure ventilation. So we shall understand the techniques of mechanical ventilation. There are two techniques, all right, negative pressure ventilation and positive pressure ventilation. First, let's understand the way that we breathe, regular, like normal human beings are breathing, is by the negative pressure breathing method. All right. We generate a negative intrathoracic pressure, and that is when atmospheric air is able to enter our lungs. All right. The thoracic cage expands, negative intrathoracic pressure is generated, and airflow occurs from atmosphere into the lungs. This same concept was applied towards the mechanical ventilator, and that's when came that gave rise to the negative pressure ventilation. The mechanical ventilators will provide negative pressure ventilation. So there are two mechanical ventilators which do that. So one of them is the iron lung. All right. So this iron lung came into use widespread during the polio epidemic. All right. So that is a situation during the polio epidemic. Many patients had got respiratory muscle weakness, and the iron lungs were widely used. So let's have a look at this iron lung. Now you can have a look at this device. This is an iron lung which was widely used during the polio outbreak. And this ventilator uses a negative pressure ventilation. So in this, you can see that the patient's body has been completely encased by this iron lung. All right, it just leaves the head free. The limbs are completely covered. So it had many disadvantages because the patient was not mobile. But the method used here was that a negative pressure gradient is developed wherein atmospheric air can now enter into the patient's lungs. This kind of mechanical ventilation is not used currently. And we shall have a look at the second type of device that is used for negative pressure ventilation. So here you can see that there is this patient who has a device wrapped around his chest. All right, so this is one of the chest cuirass or a chest shell. So the advantage over here is that the patient can move around freely. His hands and legs are completely free. He can be mobile, unlike the iron lung. This device, this chest shell, also uses the same concept of negative pressure ventilation. So negative pressure ventilation follows the rule of creating a negative pressure gradient, because of which there is airflow into the lungs. Now let's understand. This is all historical. So let's understand the positive pressure ventilation, because those are the mechanical ventilators that are currently used. The modern mechanical ventilators work on the concept of positive pressure ventilation. So in this, a positive pressure is applied externally on the airway inlet. Okay, and because of which a positive pressure gradient is developed and airflow occurs into the lungs. So let's see one of the images for better understanding. So here you can see that in this image, there's a patient who has been intubated and she's been connected to a modern mechanical ventilator. This ventilator is going to provide her with a positive pressure breaths. Now we should also know what are the stages in mechanical ventilation. All right. So there is inspiration, there is expiration that we normally know, right? So we have the inspiratory, okay, inspiration, then comes the cycling from inspiration to expiration, then occurs the expiration, and then the cycling over from expiration to inspiration. So during mechanical ventilation, we need to know certain terminologies, all right? So inspiration, what is going to start off this inspiration? What is the trigger, all right? So the word trigger means what is going to start off the inspiration, okay? Then comes the limit. What is the limit at which the inspiration, to which the inspiration will occur? Is there a pressure limit? All right, that this is the maximum pressure to which the inspiration will go. All right, so there is a limit which is put to the inspiration. Then comes the cycling, which is inspiration to expiration. So cycling means when will one phase move over to the next phase. That is called as cycling. All right. Now we shall go through the different modes of mechanical ventilation. Okay, so the first mode that we shall understand is the continuous mandatory ventilation. All right, so in this, there are fixed, a tidal volume is set on the ventilator, a respiratory rate is set. So if I set 10 breaths per minute, tidal volume 500, the ventilator will provide 10 breaths, tidal volume 500 ml. All right, in between this time, if the patient tries to take a breath, all right, if the patient tries to breathe, okay, the machine will not allow him to take that breath. That spontaneous effort made by the patient will be completely ignored by the machine. Okay. So because of which, if the patient is even partially awake, okay, and if he's not able to breathe, you can imagine how much of anxiety and how harrowing it can be for the patient. So in this situation, the patient has to be completely sedated and completely paralyzed. Okay. Uh, so there is no regard for the patient's own inspiratory effort. So you can understand that this mode had got certain drawbacks. So because of which there was a better mode that came into use, which is known as the volume, which is known as the AC mode, assist control mode. So we shall see that. So now let's understand the assist control mode. All right. So in this mode, just like the CMV mode, you'll set the respiratory rate, you'll set the tidal volume. The machine will provide the respiratory rate and that particular tidal volume. So if you set 10 per minute, it will provide that and it will provide the tidal volume of 500 each time. Now, in between this, if the patient tries to take an inspiratory effort, okay, so the patient tries to breathe, the machine will sense it. All right. The ventilator will sense that the patient is making an effort. Let's not ignore that effort. Let's help the patient to take that breath. All right. Hence the name assist because it is assisting the patient to take his own breaths. All right. Control because yet it is going to provide the controlled breath. So the patient tries to take a breath, the machine knows that any breath provided, the tidal volume I have to deliver is 500 ml. Why? Because that has been set on it. Okay. So the patient tries to take a breath. The machine will provide support and ensure that 500 ml tidal volume is provided to the patient. Okay. So it's going to assist the patient in taking the breaths. Here, all the ventilatory work, all the work of breathing is done by the machine. The machine only has to sense that yes, the patient is trying to take, let's help the patient. So all the work of breathing is done by the machine. Hence, it is said that this mode is providing full ventilatory support to the patient. Okay. And it is usually this mode that we start off mechanical ventilation with. All right. And gradually we wean the patient off this mode. Okay. And so now we shall next go and see there's something known as the IMV mode, which is the intermittent mandatory ventilation mode. Okay, so now let's understand the IMV mode, which is the intermittent mandatory ventilation mode. So in this mode, again, you'll put the preset, a tidal volume will be set, a respiratory rate will be set, and the machine will deliver that. In between, if the patient is trying to take spontaneous breaths, the machine won't suppress it. The machine will allow the patient to take those spontaneous breaths. But because this is not the assist mode, it will not assist the patient's spontaneous breaths. Okay. So whatever variable tidal volume that the patient is taking, it will allow the patient to take it, but it will not support those breaths in any way. That is completely on the patient. All the work of breathing done for the spontaneous breath is completely done by the patient. The ventilator is not helping the patient. The ventilator will only provide the preset number of mandatory breaths it has been told to provide. All right. So what is the problem that can occur in this? Suppose there is a mandatory breath which has to be given. All right. And just about that time when the mandatory breath is going to the patient also, takes a spontaneous effort. Okay. And if I had set that mandatory breath at 500 ml and coincidentally, the patient also has taken a breath at the same time and the patient's efforts, allowed him to take 200 ml of tidal volume, it's going to cause a summation. So 500 ml plus 200 ml, ultimately the lungs will receive 700 ml of tidal volume. All right. So this problem is called breath stacking, and this problem can occur in this IMV mode. Okay. Now, this breath stacking problem does not occur in the next mode that we shall see, which is the SIMV mode, which is a synchronous intermittent mandatory ventilation mode, which was a mode a step better than this mode. Okay. In the assist control mode, now if you will ask me that, okay, the patient is, the mode that we saw before, the patient is allowed to take breaths in that, the machine is supporting those breaths. So you might tell me if I have set 10 breaths in that and the patient is taking more, so lot many breaths will go, right? That's what you'll tell me that in the AC mode, ma'am, you told 10 breaths, but the patient is taking 12 himself. Would that mean that 22 breaths would go? No, in that AC mode that we saw before, all right, if set breaths are 10, the patient is taking 12, the machine will not provide its own 10 breaths. Instead, it will overlap its 10 breaths along with the patient's 12 breaths. All right. So out of those 12, 10 will be fully supported by the ventilator, will be provided by the ventilator, whereas 2 wouldn't be. All right. So it's not like a summation will happen over there. Okay. But that kind of summation is going to happen in this mode, in this IMV mode. Okay. Because there's no synchrony between the set patient, between what the patient is taking, what the machine is giving. The machine is told to be given, 10 per minute, irrespective, it will give 10 per minute. Okay. Irrespective of the patient's efforts. Patient is taking, maybe, he's taking 10 of his own. In the IMV mode, that will become 10 plus 10, 20. Okay. But that situation does not occur in the AC mode. That situation also does not occur in the next mode that we're going to see, which is the SIMV mode. Okay, so now let's understand the SIMV mode. So in this mode, again, you will, just like the IMV, you set the tidal volume, you set the respiratory rate. But this mode, no breath stacking will occur. So what is the secret behind no breath stacking occurring? All right, that's known as the synchronization window. All right, there's something called as a synchronization window that occurs, that is there. So that window is usually of 0.5 seconds. So before the machine is about to give its mandatory breath, for zero point 0.5 seconds before that time, it will start sensing, is the patient taking any effort? If yes, it will make sure there's a synchrony. So the patient's effort occurs and the mandatory breath will be given along with that patient's effort which has been taken. All right. So the mandatory breath will get a little bit preponed by a zero point 0.1 second or by a zero point 0.2 second, and it will be given along with the patient's own spontaneous efforts. All right. So there is a synchronization between the patient's efforts and the mandatory breath that is to be given. So breath stacking will not occur. The SIMV mode is a very popular mode for weaning of the patient from the mechanical ventilator. So usually the first mode that we go for is the AC mode, the assist control mode, and gradually you wean off the patient to the SIMV mode. Okay, let's look at the next mode, which is the pressure support mode. Okay, so let's look at the next mode, which is the pressure support mode. This is again a weaning mode of ventilation. A pressure is set on the ventilator. That particular pressure support will be given to the patient every time the patient tries to take a breath. So pressure support, the only factor that you are inserting into the ventilator is the pressure at which the support has to be provided. No respiratory rate is entered, no tidal volume is entered, just the pressure with which the breath of the patient has to be supported. So as you can see, this pressure support is it's a mode wherein the patient is initiating all the breaths by himself, but each breath is supported by a certain pressure so that it becomes easier for the patient to complete his breaths. All right. So therefore, it is a weaning mode of ventilation. Then we should just quickly understand what is pressure controlled ventilation and volume controlled ventilation. So pressure controlled ventilation is wherein you put the set pressure that, okay, inspiration has to be given, and this is the pressure limit up to which the inspiration has to be provided. All right. Volume control ventilation, yes, the volume is controlled. Okay, set ml is 500 ml. Okay, so 500 ml tidal volume has to be delivered by the ventilator. So these two modes are actually used in combination with the AC mode or in combination with the SIMV mode. So it can be the volume AC mode, wherein it's a volume control ventilation along with the assist control, or it can be the pressure control ventilation along with the assist control. All right. Or you might use the volume mode along with the SIMV or the pressure mode along with the SIMV. So it is an add-on mode with the other modes, all right, wherein you decide the pressure is either the pressure is decided of inspiration or the tidal volume of the inspiration is pre-decided. Let's just quickly understand a small, mode that is on the ventilator, which is known as the PEEP. So PEEP is something you can provide to the patient during mechanical ventilation. So what is PEEP? It is positive end expiratory pressure. So you might say, okay, this is a pressure that's applied only at the time of expiration, but no, this pressure is provided to the airway during inspiration and expiration. So during the whole ventilatory cycle, the PEEP will be present. Okay. The usual PEEP that we apply is 5 centimeters of water. Now, why is this PEEP applied? So that during expiration, the alveoli of the patient shouldn't collapse. All right. So physiologically, we have a PEEP right now. Like when the person who's not intubated, not on the mechanical ventilator, their alveoli do not collapse and expand every time the patient is breathing. Why? Because there's something known as physiological PEEP. This PEEP has been lost in a patient who's intubated. Okay, so hence we have to provide PEEP to this patient. So usual PEEP that is provided to the intubated patient is 5 centimeters of water, and then it can be, a step up can be provided based on the oxygenation status of the patient. So this recurrent, collapse of the alveoli is prevented and the damage to the alveoli is prevented by putting the PEEP, and hence ventilator-induced lung injury, VILI, can be prevented. Now, PEEP, if you provide it to a patient who is not intubated, who's on CPAP, so that is, PEEP which is provided to a patient who is not intubated is called as CPAP. All right. The terminology is different, but the concept is the same. So let's now understand what is the airway management that we have for a patient who has to be provided with mechanical ventilation. So for the airway management of this patient, so it depends if you're providing invasive ventilation or non-invasive ventilation to the patient. So if you're providing invasive ventilation, that means you're using a definitive airway and invasive airway. So that means you're using the endotracheal tube or tracheostomy tube is used for the patient. All right. So endotracheal tube, the life of it is only for 2 to 3 weeks. You cannot use it for more than that because it can lead to other complications such as subglottic stenosis. So if a longer duration ventilation is anticipated, you should go for a tracheostomy tube. It can be kept in place for more than 3 weeks. You also have the non-invasive ventilation, so which is a very tight-fitted mask that is placed on the patient's, which covers the patient's nose and mouth, and this provides non-invasive ventilation. So it's known as a CPAP mask or the BiPAP mask. All right. Okay, so now let's understand what are the complications that are occur with mechanical ventilation. So complications could be related to the tube, endotracheal tube, all right. So the tube might be in the wrong place, okay. It might be in the bronchus, it might be in the esophagus, there might be trauma during intubation, the tube might be blocked by some secretions, okay. There might be traumatic intubation or accidentally the tube may come out. So these are some complications related to the tube. Then there are ventilator related complications. So you have unintended, hypo or hyperventilation might occur, CO2 retention or, excessive CO2 washout may occur. Patient might have ventilator induced lung injury, ventilator associated pneumonia. The other complications are barotrauma, volute trauma, atelectic trauma. All right. Now, what are the a patient who's on mechanical ventilation might require sedation and paralysis. That is, the patient is fighting the ventilator. He's not, cooperative, anxious, agitated. So there are certain drugs that can be provided for sedation and paralysis. So for sedation, we've got this list of drugs that we usually use. So there are benzodiazepines, most commonly used as midazolam, opioids such as fentanyl, morphine. You have hypnotic, which is propofol. You also have the alpha agonist, which is dexmedetomidine, which is the newer drug, which is used for ICU sedation. Also relaxants, there is a skeletal muscle relaxants, which are used, which is the non-depolarizing muscle relaxants, which is vecuronium, hydrocuronium, can be used for sedation and paralysis. Now we should see the monitoring. I've enlisted very few monitoring, methods in a patient in the ICU. So you have to monitor the patient's heart rate, right? See if there's bradycardia, tachycardia. All right, you have to see for the ECG if there's any arrhythmia. Saturation monitoring has to be done. The FiO2 monitoring has to be done. That is the FiO2 that you have set on the ventilator. Is it actually providing that much or is less being delivered? All right. The airway pressures have to be monitored whether very high pressures are going to the patient or no, because if very high pressures are being delivered, it can cause fatal trauma. Monitoring that has to be done, which is the NIBP or the IBP. So NIBP is a non-invasive BP, which is through the cuff. IBP is the invasive BP monitoring, which is done when the patient is on some kind of, inotropic supports, so that you get the beat to beat, you get the beat to beat BP reading. All right. Also, the ABG has to be monitored regularly, especially the patients on the ventilator. You want to switch the modes of ventilation. You want to titrate the FiO2. You need to do the ABG so that you can come to know the PaO2 values and the PaCO2 values, the pH of the patient. All right. Let's now understand what settings should be put initially on the ventilator when we are starting with mechanical ventilation. Here I have enlisted the settings that have to be put on the ventilator when you start with mechanical ventilation. So the very first is the AC mode. All right. We have to select a mode. So the mode of choice is the AC mode, which is the assist control mode. And as I told you, the assist control mode will give the compulsory breath as well as assist the breath that the patient is taking himself. So in case the patient starts coming out of anesthesia, the patient starts recovering and he starts taking his own breath, he can take his own breath. So this mode can be either the volume AC mode, that is volume control ventilation, pressure control ventilation, right? I had explained those two. So either of the two can be selected. Either it can be volume or it can be pressure AC. Then we have to set the FiO2, which is a fraction of inspired oxygen. So whether the patient should get receive 100% oxygen, 80% oxygen, how much percent of oxygen should the patient receive? So at the start, always start off with an FiO2 of 100%, gradually bring it down over the next 24 hours, at least to 50%. But that has to be done while you're looking at the saturation of the patient, as well as when you're keeping in mind the PaO2 of the patient. The tidal volume that you should be setting is 8 to 10 ml per kg. The respiratory rate that you should be putting on the ventilator is at least 12 breaths per minute. All right. You can also set a PEEP of 5 centimeters of water, which is the basic PEEP, and a trigger. So a trigger, that is what will help the machine to sense that the patient is taking his own breath. All right. So the patient starts inspiring and generates a flow of 1 to 3 liters per minute during inspiration. It will trigger off a breath by the ventilator. If the patient is generating, a negative intrathoracic pressure of -1 to -2 centimeters of water, that will trigger the ventilator to assist that breath of the patient. So that is the trigger. Now let's understand how to wean off the patient from the mechanical ventilator. For weaning, the first criteria that you look at is the readiness criteria. That is the patient ready to start the weaning process. All right. So the first system that we look at is the respiratory system. So the patient should be able to take his own breaths. All right. The patient's PaCO2 should be normal. His PF ratio, that is the PaO2 by FiO2 ratio, should be more than 200. His FiO2, that is the amount of oxygen that you're giving to the patient, should be less than 50%. PEEP requirement should be less than 8 centimeters of water. Okay. In the cardiac system, there should be no tachycardia. There should be no shock. Okay. Shock means that is, I mean to say, no hypotension. And if there is hypotension, then the BP should be maintained with very minimum support, or the BP should be almost normal. That is when you can say that the patient is ready. Okay. CNS, the GCS should be more than 13. The patient should not have fever, no electrolyte imbalances. Then we can start off with the weaning trial. Now that we know that the patient is ready for weaning, so let's see the next step of weaning, which is known as a spontaneous breathing trial that has to be given to the patient. So it can be done while the patient is connected to the ventilator. It can also be done while the patient is disconnected to the ventilator. So there are two ways of doing it. So on ventilator method is that you can be in the SIMV mode, or you can bring the patient to the pressure support mode. So the patient is in the SIMV mode. You gradually reduce the number of mandatory breaths that you're giving to the patient. So step it down by 2 breaths per minute. All right. And gradually reduce the pressure support that you're providing to this patient. And ABG has to be done every 30 minutes. And once you see that, the PaO2 is acceptable, all right, the respiratory rate that you're set, the mandatory rate has come down to 2 to 4. I do not say that the patient's rate, the mandatory rate on the ventilator has come down to 2 to 4. That is when you can say that, yes, the weaning has been successful. The other option is that you do it on the pressure support mode, where you start titrating the pressure support you're providing to the patient. So bring it down gradually by 2 centimeters of water. And then ultimately what you have to look is at how much is the tidal volume the patient is taking. Is he taking at least 4 to 6 ml per minute? All right. Is his respiratory rate not too high, not too low? Is it less than 30 per minute? All right. Then is the PaO2 acceptable? Is the pressure support that you're providing with the ventilator around 5 centimeters of water to 8 centimeters of water? All right. That means now the patient has been successfully weaned of the ventilator. The other option is that you can do it completely by disconnecting the ventilator. So you disconnect the ventilator, you put the patient on the TPs, and you start off with the duration of disconnection for 10 minutes. So you disconnect the patient for 10 minutes and you observe, all right? And you see for the rapid shallow breathing index, okay, which is a ratio of the respiratory rate upon the tidal volume that the patient is taking. If the rapid shallow breathing index is less than 100, that means you can now safely extubate this patient. Now, when is it that you will abort this trial? Okay, the breathing trial is when if the heart rate goes too high, too low, the patient goes into hypertension, hypotension, chest retractions, extreme fatigue, all right, or there are arrhythmias that develops, just abort the trial and connect the patient back to the ventilator. So here we have completed an overview about the topic of mechanical ventilation. This is a very vast topic, and I have tried to make it as concise as possible.